So up to 48% of women experience vaginal laxity. But when researchers actually went and asked their partners about it, over 72% had never even noticed a change.
Which is, I mean, it's just a wild statistic.
Right. So today we're doing a deep dive into this, like this massive disconnect between what you might feel in your own body and what a doctor can actually measure with their clinical tools. Because there is a surprisingly vast gap between the two.
Yeah, and it's a really fascinating tension in modern urogynecology right now.
Hmm.
You have this condition that profoundly alters a person's quality of life. But for the longest time, the medical community, they struggled to even standardize a definition for it.
Right.
We're basically dealing with this landscape where, anatomical realities and subjective anxieties are totally overlapping.
Hmm.
And navigating that means we have to move past some pretty outdated diagnostic assumptions.
Absolutely. Which means, I think, we need to clearly establish what introital laxity actually is at a functional level, because even in clinical settings, it constantly gets conflated with pelvic organ prolapse.
Oh, all the time. Yeah. And the confusion stems from the fact that they often share the exact same root causes. But mechanically speaking, they're entirely distinct issues.
Totally different.
Right. So introital laxity, according to the IUGA and the ICS, is defined strictly as a subjective complaint. It's the feeling of excessive flaccidity or, a loss of tension, specifically at the vaginal opening, the introitus. We're talking about the structural integrity and the compliance of the tissue itself.
Right. Whereas pelvic organ prolapse, or POP, is basically a structural hernia. Like, prolapse is when the surrounding organs, so the bladder, the rectum, the uterus, when they physically drop from their normal anatomical positions down into or even beyond the vaginal canal.
Exactly. To visualize the biomechanics here, if you think of the pelvic floor as a hammock that's supporting those organs, laxity is a change in the actual fabric of the hammock itself.
The fabric just gets stretched out.
Right. The material has lost its tension, its recoil. It just loses that innate elasticity. Prolapse, on the other hand, is when the person lying in the hammock actually drops through it because the entire structural support has just given way.
And, to take that hammock analogy just a little step further, it's not always just the fabric that changes. Sometimes the ropes anchoring that hammock to the trees, like the levator ani muscles, they suffer actual physical damage.
Yes, that is the crucial distinction to make. Laxity is about the mucosal and connective tissue compliance, while prolapse is about macroscopic organ displacement.
Got it.
And, I mean, they can definitely coexist, which really muddies the diagnostic waters.
Mhm.
But understanding that laxity is a fundamentally different tissue-level issue is, like, the first step in addressing it.
So if we look at the sheer physics of why that tissue changes in the first place, the clinical data points heavily to this compounding combination of, well, life events and biology.
Yeah.
Statistically, vaginal childbirth is the primary mechanical trigger. But I know we're not just talking about general stretching here. Is this just an inevitable part of the aging process, or do specific traumatic events, like a difficult childbirth, act as the main trigger?
It's really the compounding nature of all of it. Because with childbirth, we're talking about immense acute biomechanical strain. During delivery, the levator ani muscles and the pubocervical fascia, they are stretched to their absolute physiological limits.
Which sounds incredibly intense.
It is. And often there's macroscopic trauma. Like you can see cases of levator avulsion where the muscle actually just detaches from its insertion point at the pubic bone.
Oh, wow. Just tears right off.
Exactly. But even if you don't have a full avulsion, the sheer distension causes these micro tears in the muscle fibers. And it causes permanent alterations to the extracellular matrix of the fascia.
Right, because the tissue is basically being asked to stretch way beyond its elastic limit. So it enters this plastic phase where it just can't fully recoil back to its baseline state.
Precisely. And the risk of that permanent structural fatigue really compounds if you have multiple vaginal births or, a prolonged second stage of labor.
It permanently alters the baseline architecture. But childbirth is usually just the initial catalyst, right?
Right.
Because as you age, the underlying biology starts compounding that initial mechanical trauma, particularly the hormonal shifts we see during perimenopause and menopause.
Exactly. The genitourinary syndrome of menopause.
Right. And since you, our listener, likely already understands the estrogen crash that comes with menopause, let's look at what that actually does to the cellular matrix of the vaginal wall. Because it's not just like a general thinning. It is a fundamental shift in the tissue's composition.
Yeah, the loss of circulating estrogen triggers this whole cascade of changes at the cellular level. The blood flow to the mucosal layer drops significantly.
Which means less oxygen and nutrients.
Right. The capillary beds shrink, and the fibroblasts, which are the cells responsible for producing collagen and elastin, they become much, much less active.
So the tissue is literally losing its structural scaffolding.
Exactly. It loses the scaffolding and its ability to retain moisture, which leads to vulvovaginal atrophy. The mucosal walls get thinner, they become more friable, and they just entirely lose that natural plumpness that gives you that feeling of tension.
So you have the situation where mechanical trauma from childbirth has already altered the muscular support, and now, years later, hormonal changes are degrading the mucosal tissue from the inside out.
It's a double whammy.
And that's before even factoring in genetics, right? Like connective tissue disorders.
Oh, absolutely. Conditions like Ehlers-Danlos syndrome, they systemically alter collagen synthesis across the whole body.
Right.
If your body inherently produces faulty collagen, your fascia and your ligaments are going to lack that normal tensile strength to begin with. So that makes the pelvic floor highly susceptible to laxity, regardless of whether you've ever gone through childbirth or menopause.
That makes total sense. And I imagine lifestyle factors play a role too, like chronic intra-abdominal pressure.
Oh, definitely. Things like persistent coughing, obesity, or heavy lifting that constantly pushes down against that already weakened tissue, and that just exacerbates the flaccidity over time.
Okay, so if the physical hammock is weakened by all these compounding factors, you would naturally assume a doctor could just, look at it, take a measurement, and quantify the slack.
You would think so.
Right, but measuring a subjective feeling is where the clinical tools basically completely fail. And this brings us to a really fascinating piece of research from Alison Polland and her team, known as the DevelopUS study.
Yeah, the DevelopUS study.
Right.
The methodology of that study was specifically designed to expose this exact diagnostic blind spot we're talking about.
Right.
They wanted to see if a patient's subjective experience of laxity actually correlated at all with the objective physical measurements taken by a physician during a standard pelvic exam.
So they took this dual approach. On the subjective side, they asked patients to rate their own feeling of laxity using the vaginal laxity questionnaire, the VLQ. It's this standardized 1 to 7 scale, 1 being very loose, 7 being very tight.
And then on the objective side, the doctors used the pelvic organ prolapse quantification system, the POPQ.
Right, which is basically a highly standardized clinical ruler system. They use it to measure specific anatomical distances. And in this study, they focused heavily on the genital hiatus, which is essentially measuring the width of the opening while the patient bears down, using the hymen as a reference point.
Right. And the core assumption in urogynecology for decades had been that a wider anatomical measurement on that ruler would directly translate to a greater sensation of looseness for the patient.
But the findings completely shattered that assumption. Like the DevelopUS study found absolutely no correlation between the physical exam measurements of the genital hiatus and a woman's subjective VLQ score. 0.
None at all. It's incredible. You could have a patient scoring herself as feeling extremely loose, like it's having a massive impact on her quality of life. And the physical ruler measurements wouldn't show any clinical widening or prolapse whatsoever.
Wait, so if a woman feels loose, but the doctor's physical POPQ measurements don't show clinical prolapse, is the medical community historically implying it's just in her head?
Unfortunately, yes. Historically, there has been a huge tendency in medicine to dismiss that subjective experience as purely psychological if it can't be measured on a ruler.
Wow.
And that is a really dangerous trap. But it's one that modern urogynecology is actively trying to dismantle now. Just because a clinical ruler cannot measure the loss of tissue friction or those subtle changes in mechanoreceptor sensitivity, it doesn't mean the physical changes aren't real. The ruler is just the wrong tool for the job.
It's like attempting to measure the quality of a fabric by only looking at the dimensions of the room.
That's a very apt way to put it. And, to be fair to the broader scientific landscape, other researchers have used different tools, like Dietz and his team, using 3D or 4D pelvic ultrasounds.
Oh, interesting.
Yeah, and they actually have found measurable associations between feelings of laxity and the actual distensibility of the pelvic floor muscles under pressure.
Yeah.
But the DevelopUS study proved definitively that a traditional physical exam cannot invalidate a patient's symptoms.
Right.
Which is exactly why the standard of care is shifting so aggressively toward patient-reported outcome measures, or PROMs, like the EPQPF questionnaire. Because in this case, the subjective experience is the pathology.
Absolutely, because the fact that it's difficult to measure on a standard ruler does not lessen its real-world impact. When you dig into the data on how this alters a patient's quality of life, the ripple effect is just profound, especially concerning sexual function and intimacy.
Oh, without a doubt. Physiologically, if the vaginal tissue loses its tension and compliance, there is an immediate, direct decrease in physical friction during intercourse.
And friction is directly tied to neurobiology. The vaginal wall contains rugae, these little folds of mucosal tissue that provide texture and allow for stretch. When those folds flatten out due to laxity and atrophy, you lose the mechanical stimulation required to actually trigger the nerve endings.
Exactly. When that mechanical stimulation drops, the mechanoreceptor firing rates decrease, and that leads to diminished overall sensation.
Which obviously impacts arousal.
Right. When sensation diminishes, the whole physiological arousal cycle gets interrupted, making it significantly more difficult to achieve orgasm. And when you combine that lack of friction with the severe decrease in natural lubrication caused by those hormonal shifts, sex can shift from being just unfulfilling to being actively painful.
Right, you're dealing with dyspareunia driven by dryness alongside a total loss of mechanical pleasure. And then when you look at the psychological data, you see a massive loss of sexual confidence. You see plummeting libidos.
Yeah, the psychological toll is immense.
You see this intense self-consciousness being carried into the bedroom, which creates negative friction in relationships. But this brings us back to that staggering data point I mentioned at the very beginning regarding partner perception.
Right, from the Develop study. They asked these women if their sexual partners had ever commented on their vaginal laxity.
And over 72% of partners had never made a single comment. And of the minority who actually did comment, 21% remarked on the vagina being tight. Only 7% of partners commented on it being loose.
It's wild.
And this is from a study pool where the women themselves were actively seeking care for feelings of laxity.
The disparity between self-perception and partner perception is just enormous.
That is a massive blind spot. It sounds like the psychological weight, the anxiety, and the self-consciousness a woman carries about laxity is often far heavier than what her partner is actually experiencing. Like, it upends the whole narrative.
It really does. You're looking at the anxiety of perception. Because there is such a profound lack of open dialogue about how the pelvic floor naturally evolves after childbirth and through menopause, women internalize this really static, useful ideal of what their bodies, quote-unquote, should feel like.
Right.
And they project that anxiety onto their partners, assuming a level of physical judgment that the data proves simply isn't happening.
Wow. So if you are experiencing this, whether the laxity is driven by the structural trauma of childbirth, the cellular degradation of menopause, or purely a subjective change in sensation, understanding the biomechanics is empowering, but you also need to know the actual mechanisms of the treatments available to reclaim control.
Yes, and thankfully, the treatment landscape has expanded significantly over the last decade.
Mm.
It moves all the way from conservative physiotherapy up to energy-based interventions and ultimately to surgical reconstruction.
Okay, so let's start with the conservative approach, targeted physiotherapy, or PFMT, because I think it's crucial to dispel a really persistent myth about what these exercises actually do. Doing Kegels does not tighten the vaginal tissue itself, does it?
No, it doesn't, and that's a huge misconception. The vaginal wall is composed of smooth muscle, mucosa, and connective tissue. It is not skeletal muscle. You cannot voluntarily flex it to create hypertrophy or make it grow.
Right.
What targeted physiotherapy does is strengthen the surrounding striated muscles of the pelvic floor, specifically that levator ani complex we talked about.
So going back to our house analogy, doing Kegels is like reinforcing the muscular scaffolding around the house, whereas you're not actually attempting to shrink the walls of the room inside.
Perfect analogy. By creating hypertrophy in the levator ani muscles, you increase the resting tone of the entire pelvic floor. So a thicker, stronger muscle provides a firmer backboard against the vaginal wall.
Ah, I see.
Even if the mucosal tissue itself remains somewhat flaccid, the strengthened muscles dynamically close that genital hiatus and provide a tighter, more supported environment, which significantly increases the feeling of friction and sensation during intercourse.
Okay, but if the scaffolding is strong, and the issue lies purely in the compliance of the mucosal walls themselves, then the treatment shifts
Right.
to the rapidly expanding field of entity-based devices, or EBDs.
Yes, exactly.
We're talking about non-surgical interventions here, using specific fractional lasers like Earway AA or radiofrequency devices like Viviv.
Right, and the mechanism of action for these devices relies on controlled thermal injury. The device delivers precisely calibrated heat into the submucosal layers of the vaginal tissue, usually raising the temperature to around 40 to 45 degrees Celsius.
And that heat is basically designed to intentionally cause microscopic damage to the existing degraded collagen fibers, right? Causing them to denature and contract immediately.
Exactly. It acts as a biological trigger. The thermal damage initiates the body's natural inflammatory healing cascade. And this cascade aggressively stimulates those dormant fibroblasts we mentioned earlier, prompting them to synthesize brand new collagen and elastin.
Neocollagenesis.
Yes, neocollagenesis. So over the course of several weeks, the tissue literally remodels itself. It restores the structural integrity, elasticity, and even increases local vascularization to combat that dryness.
It's utilizing the exact same biological mechanism as laser skin resurfacing on the face, but applied to the vaginal mucosa.
Precisely.
Now, while these devices are super popular and have shown substantial anecdotal success for mild to moderate laxity, we should note that the long-term, rigorous clinical data is still catching up compared to traditional methods.
It is. They offer a really compelling middle ground for patients wanting to avoid the operating room, but they aren't a permanent fix against the continuous progression of aging. For severe cases, particularly when laxity is accompanied by structural prolapse, surgical intervention remains the definitive option.
Right. Vaginoplasty or anatomical reconstruction. This is where a surgeon addresses both the hammock fabric and the anchoring ropes simultaneously.
Exactly. The procedure typically involves an anterior or posterior colporrhaphy or a perineoplasty. The surgeon physically dissects the vaginal epithelium, excises the excess, stretch mucosal tissue, and then deeply sutures the underlying endopelvic fascia and levator muscles back together across the midline.
So you are physically narrowing the anatomical caliber of the vaginal canal and reestablishing the structural support that was lost during childbirth.
Yes, and it is highly effective at restoring the physical dimensions. But, it fundamentally alters the tissue architecture. Because it involves excision and suturing, it carries standard surgical risks, including the development of rigid scar tissue.
Oh, right.
And if the reconstructed canal is made too narrow, or if the scarring limits natural distensibility, it can ironically induce severe pain during intercourse down the line. It requires a highly skilled approach to balance anatomical tightness with functional elasticity.
Wow. We have really covered the entire biomechanical spectrum of this condition today. Introital laxity is a highly common, often underreported condition distinct from prolapse. It's this complex physiological reality driven by the acute trauma of childbirth and the cellular shifts of menopause.
It really is.
And it notoriously defies simple measurement with clinical rulers, creating a frustrating paradox where objective exams fail to capture a deeply subjective loss of sensation.
Yet that subjective experience is entirely valid. It dictates sexual function, it dictates neurobiological sensation, and it carries an immense psychological weight, even when the data reveals partners are largely oblivious to the physical changes.
Which is such a wild takeaway. So whether the solution involves bulking the muscular scaffolding through physiotherapy, triggering neocollagenesis with lasers, or anatomically reconstructing the tissue, then my critical step is just bringing it out of the shadows, acknowledging the mechanics of what is happening in your own body without shame.
Absolutely. The transition in modern medicine to prioritize your reported experience over a static ruler measurement is a massive, massive step forward in validating and treating this condition.
Which leaves us with a really intriguing look toward the future. We spent a lot of time analyzing how disconnected cold clinical measurements are from your highly subjective experience of your own tissue.
Yeah.
Considering that diagnostic gap, how might the evolution of wearable technology and at-home biofeedback devices completely change the landscape? Imagine a scenario where you could accurately map your own pelvic floor muscle tone, tissue elasticity, and neural sensitivity over time using a smart device in your own home, eliminating the need for a subjective clinical exam altogether.
Oh, that would put the diagnostic power directly into the hands of the patient, completely bypassing the clinical blind spots we talked about entirely.
It could finally provide the exact data needed to match the subjective experience. Well, thanks for taking this deep dive with us.